Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 417 of our pharmacotherapy series, which covers neoplastic disorders and their treatment, general principles. My first question to you reads, STK, a 16-year-old boy, presented to the emergency department with a painful, swollen right leg. X-ray examination confirmed a fracture that appeared to be caused by a tumor mass in the bone. Biopsy of the bone mass confirmed osteogenic sarcoma. A chest X-ray study showed 3 nodules that were also believed to be malignant tumors. So my question to you reads, does STK also have lung cancer, or are the tumors in STK's lungs metastases from the sarcoma in his leg? STK does not have lung cancer. Tumor nodules in his lung are most likely metastases from the sarcoma in his leg. The ability of cancer cells to disseminate and form metastases represents their most malignant characteristic. Tumor metastases to distant sites generally have a greater effect than the primary tumor on frequency of complications and patients' quality of life. Metastases also have a greater impact than the primary tumor on mortality, with metastases associated with most cancer-related deaths. Consequently, individuals diagnosed with metastases face a worse prognosis. Cancer cells must develop new blood vessels to obtain nutrients and spread to distant sites, that is, metastasize. In response to low oxygen supply, hypoxia, and other factors, cancer cells and surrounding tissues secrete growth factors that stimulate growth of new blood vessels, angiogenesis, from existing blood vessels in surrounding normal host tissue. Vascular endothelial growth factor, abbreviated as VEGF, platelet-derived growth factor, abbreviated as PDGF, and basic fibroblast growth factor, abbreviated as BFGF, are growth factors needed for sustained endothelial cell growth. Once released by tumor cells, these growth factors bind to tyrosine kinase receptors on the surface of endothelial cells of existing blood vessels and activate a series of intracellular relay proteins that transmit signals to genes in the nucleus to produce factors required for new endothelial cell growth. Once older endothelial cells become activated by growth factors, they begin making matrix metalloproteinase, abbreviated as MMP, enzymes. These enzymes destroy the extracellular matrix of surrounding cells, allowing older endothelial cells to invade the extracellular matrix and begin cell division. This process of invasion and proliferation is repeated several times until new blood vessels are formed. Tumor cells can use these newly formed blood vessels to facilitate their spread to distant locations. Cells must break away from the primary tumor and travel to other sites in the body to form metastases. Normally, cells adhere to one another and the extracellular matrix. The cell-to-cell adhesion molecules are called cadherins, and the cell-to-extracellular matrix molecules are called integrins. In cancer cells, these molecules are often absent, allowing tumor cells to easily move away from the primary tumor mass. Once a tumor cell leaves the primary mass, it travels through the blood vessels and lymphatic system within the body to form metastatic site or sites. Usually, tumor cells spread to the first capillary bed they encounter after their release from the primary tumor. If the primary site drains its blood supply into the vena cava, the cancer cells will reach the capillary bed in the lung. Similarly, if the primary site drains its blood supply into the portal circulation, the cancer cells will reach the capillary bed in the liver. In addition, cancer cells can potentially pass through the first capillary bed they encounter and enter the arterial circulation, where they can distribute to other organs and tissues throughout the body. Growth conditions, e.g., growth factors, physiologic conditions, within a tissue or organ also can determine the location of a metastatic site. After a cancer cell establishes a metastatic site, it must again undergo angiogenesis to ensure continued growth. Together, angiogenesis and hematogenous or lymphatic spread help cancer cells invade healthy tissues and increase morbidity and mortality associated with the disease. The next question reads, MKM, a 44-year-old woman, asks you about vaccines to prevent cervical cancer. My question to her is, should MKM consider vaccination for her daughter or her son? Would this substitute for pap smear screening for her daughter? The human papillomavirus is primarily transmitted through sexual contact. Serotypes 16 and 18, abbreviated as HPV-16 and HPV-18, cause approximately 70% of cervical cancers. There are 3 different human papillomavirus vaccines available, each requiring 3 intramuscular injections over the course of 6 months. The human papillomavirus bivalent vaccine, marketed as Cervarix, includes human papillomavirus type 16 and 18, whereas the human papillomavirus quadrivalent vaccine, Gardasil, includes human papillomavirus type 6, 11, 16, and 18. Both vaccines demonstrated efficacy in reducing the incidence of cervical intraepithelial neoplasia, abbreviated as CIN, a premalignant lesion that can lead to cervical cancer. Because the progression of human papillomavirus infection to invasive cervical cancer requires several years to possibly decades, cervical intraepithelial neoplasia is utilized as a surrogate efficacy endpoint in human papillomavirus vaccine clinical trials. It is anticipated that the use of human papillomavirus vaccines will ultimately lead to a reduction in the incidence of cervical cancer. The human papillomavirus 9-valent vaccine, marketed as Gardasil 9, includes the same human papillomavirus types as the bivalent and quadrivalent vaccines 6, 11, 16, and 18. But with 5 additional human papillomavirus types, 31, 33, 45, 52, and 58, increasing prevention to approximately 90% of cervical cancers. The HPV quadrivalent and 9-valent vaccines are also approved for the prevention of vulvar intraepithelial neoplasia, abbreviated as VIN, and vaginal intraepithelial neoplasia, abbreviated as VAIN, in females, as well as prevention of human papilloma virus-related genital warts and anal cancer in males. However, there are no data to support the use of these vaccines to prevent other cancers associated with human papilloma virus, such as penile cancer or head and neck cancers. Routine pap smear and human papilloma virus screening should continue for vaccinated women because the vaccines do not prevent all oncogenic types of human papilloma virus. The duration of vaccine-induced anti-human papilloma virus immunity is also unknown. MKM should consider human papilloma virus vaccination for her daughter. All 3 vaccines are indicated in females of 9 to 26 years of age, but the vaccines are most effective if initiated before sexual activity. Whether or not MKM's daughter is vaccinated, she should still receive routine pap smear screening according to current guidelines. The human papilloma virus quadrivalent and 9-valent vaccines are approved in males of 9 to 26 years of age. Therefore, MKM should also consider vaccination for her son. The Centers for Disease Control recommends human papilloma virus vaccination for all females and males at the age of 11 to 12 years. The next case reads, JSK is diagnosed with breast cancer after a biopsy of a large breast mass. Chemotherapy, radiation, and surgery are commonly used to treat patients diagnosed with breast cancer. So my question to you reads, what information is needed to select a treatment plan for JSK? The stage of the cancer, as well as the histologic diagnosis, influences both the treatment selection and prognosis. Staging is the process that determines the extent or spread of the disease. Determining the stage of the cancer typically requires tests that can physically or radiographically measure the size of the primary tumor and assess for evidence of tumor spread, e.g., radiographs, computed tomography scans, magnetic resonance imaging scans, or positron emission tomography scans, and pathologically examine regional lymph nodes. Clinicians also evaluate symptoms, e.g., pain, or signs, e.g., swelling, abnormal laboratory findings, that may indicate tumor involvement at a distant site. Staging schemas have been developed for all major types of cancers. For solid tumors, the most widely used and accepted staging classification is the TNM system, which incorporates the size of the primary tumor, denoted as T, the extent of regional lymph node spread, denoted as N, and the presence or absence of metastatic spread to distant organs, denoted as M. Within each TNM category, the extent of cancer involvement is related to prognosis. Most solid tumor staging systems also incorporate the TNM classification into broader groups, called stages, to facilitate treatment decisions and comparison among patient populations. Classification of stages differs among solid tumors types. Please refer to malignancy-specific chapters for TNM staging of breast, lung, prostate, and colorectal cancers. Whereas the TNM system enables staging of solid tumors, it does not enable staging for hematologic malignancies, including leukemias, lymphomas, and multiple myeloma. Because hematologic malignancies occur in the blood cells and lymphatic tissues that are widely distributed throughout the body, the TNM staging system cannot sufficiently describe these diseases. To define the extent of disease, guide treatment, and provide prognostic information, specific staging systems have been developed for various hematologic malignancies. Staging systems for some tumors also include other characteristics to further determine the stage and prognosis of the disease, such as clinical signs and symptoms, biochemical characteristics of the tumor, or other laboratory tests. For example, the staging system used for Hodgkin lymphoma includes constitutional symptoms, i.e., fever, night sweats, and weight loss. These symptoms confer a poorer prognosis and could indicate the need for more intensive therapy. Tumor staging is done at the time of initial diagnosis and periodically during treatment to assess the patient's response to therapy. Staging should also be repeated. A. When evidence shows that the cancer has progressed during treatment or recurred after therapy to establish the most appropriate next-line therapy. And B. To enable measurement of response to that therapy. JSK needs to undergo the appropriate imaging scans, laboratory studies, and clinical evaluations so that her breast cancer can be staged. These tests may include blood tests, e.g., complete blood cell and platelet count, liver function tests, mammograms or breast ultrasounds, determination of tumor PR and HER2 status, breast MRI, bone scan, abdominal scans, and chest imaging. Once staging is completed, treatment recommendations and options can then be determined. We will now briefly look at the clinical presentation and complications of malignancy. The initial signs and symptoms of malignant disease are variable and predominantly depend on histologic diagnosis, location, including metastases, and size of the tumor. Pain secondary to compression, obstruction, and destruction of adjacent tissues and organs is the most common presenting symptom. Other common initial symptoms reported by patients with cancer include anorexia, weight loss, and fatigue. Certain symptoms, however, may be obscured by concomitant illness, such as chronic lung disease in patients with lung cancer. Some tumors cause signs and symptoms early in the course of the disease, whereas others may not cause symptoms until late in the course of the disease and after significant tumor growth. In either of these circumstances, early diagnosis may be difficult. Individuals at a higher than average risk for certain malignancies should be screened regularly to help detect early disease. Tumor involvement of the liver, kidneys, or lungs can complicate therapy by causing significant organ dysfunction and metabolic disturbances. In addition, compression or obstruction could produce a mass effect by impairing normal organ or tissue function and causing pain or other uncomfortable physical effects. Life-threatening complications that require immediate intervention include obstruction of the superior vena cava, spinal cord compression, and brain metastases. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 418.